Welcome to the program. I'm your host, Neal Howard, here on Health Professional Radio. Very glad that you could join us here on the program once again. Our guest today is going to talk about a recent study that was presented in our series on the Society of Cardiovascular Angiography and Interventions 2018 Scientific Sessions. Our guest is Dr. Peter Tajti, representing Abbott Northwestern Hospital, to talk about that study. Welcome to the program, Doctor. How are you?
Morning. I'm very good, and I also would like to introduce the study PI for Progress CTO, Dr. Blakis, who is also here with us.
Well, thank you very much, both of you, for joining us today. Let's jump right into this study and some of the revelations that came from it.
So the Progress CTO is an international multi-center CTO registry that is collecting patient information mostly from the United States, centers mostly from the United States, but also from Europe, Russia. The registry was started back in 2012, and it's an ongoing program, ongoing registry. And we presented our latest results at the SCAI meeting, and there was also a simultaneous publication in JACC Interventions.
Now, the title of the study, the hybrid approach of percutaneous coronary interventions for chronic total occlusions. What were some of the methods employed behind your study?
So the hybrid algorithm was created back in 2012 by various very experienced CT operators using various techniques, antegrade and retrograde techniques, and combining them to improve the procedural outcomes of CTO-PCI. This algorithm is an excellent tool for initial crossing strategy selection, which is based upon 4 angiographic parameters, which includes proximal lesion anatomy, the distal lesion segment, and also lesion length and the collaterals. So we are using this algorithm for treating CT occlusions by selecting the most appropriate technique. Also, a very important part of Progress CTO, the hybrid algorithm, is to alternate between the crossing strategies, not letting the procedure settle to save more contrast volume and radiation.
Was that the reason for the study? Because the traditional way of treating this Progress CTO took so much time and effort in order to properly address it?
Yeah, so I think just to jump in a little bit, I think Peter makes a great point. The problem with these lesions, like imagine you have a pipe and it's blocked, and it's very hard to get it open because it's completely blocked and you don't really know where you're going. And the usual way has been try different things the same way again and again and see if it works, which quite often it did not. The new approach has been that we try approach A. If it doesn't work, very quickly we'll go to approach B. If it doesn't work, approach C. And then keep on going on and on until we find the one that works versus trying the same thing again and again and again. So having this early change and tailoring the way we do this with the way the blockage is, that's what really makes the difference and makes the success rates get so much better than they used to be.
What about hospital stays? Is that reduced as well?
Yeah, hospital stay for those procedures is actually fairly short. It's the same as the other guys. The majority of patients are going to go home the following day. Mm-hmm. The ones, of course, who have a complication or are very sick for other reasons, then they may stay a little longer. But actually, the challenge in this case has been mainly being successful. The length of stay has been fairly short for most people before and now as well.
Okay. So basically, the length of stay isn't affected that much by the advancement in this procedure. It's simply a method of proper diagnosis and treatment a lot faster than in the traditional manner, correct?
So actually, the procedural success rate is better using this algorithm. So if we compare our results with prior studies in unselected patient population in the real world, success of these complex procedures are around 60%. However, using and combining multiple approaches, you can facilitate a better lesion crossing and better treatment with better success rate, which is up to approximately 90%, which is going to mean that out of 10 patients who come to the hospital with this kind of problem, may get the appropriate treatment in 9 of those 10 patients.
What do you see as next for this study? Where do we go from here as far as this procedure is concerned?
So the major focus from now should be to bridge the gap between inexperienced and experienced centers. So Progress CTO includes only high-volume experienced centers from 2 continents. However, in general, the cath labs might not have the volume to perform CTO-PCI as we do in Progress CTO registry. So this is also a very important point. And the major focus from now is to just bridge the gap between the low-volume inexperienced centers and the high-volume experienced centers to just have a more balanced and standardized patient treatment and referral system. We should, all of us should do it by educating and proctoring those low-volume centers to improve the outcomes there as well.
Well, I appreciate you coming in today, both of you, as a matter of fact. Some great information in our ongoing series on the 2018 scientific sessions at the Society of Cardiovascular, Angiography, and Interventions. I thank you both for coming in today and speaking with us.
Thank you very much.
You've been listening to Health Professional Radio. I'm your host, Neal Howard. Transcripts and audio of the program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to this podcast on iTunes. You can listen in and download at SoundCloud and visit our affiliates page at hpr.fm and healthprofessionalradio.com.au.